This is Module 2, and we are addressing pain control theories. We're going to review these. Remember that these are proposed theories as to how one might decrease pain based on our physiological knowledge of pain and the structures that you've just been studying. So the first theory is specificity theory of pain. This theory states that when specific nociceptors are stimulated, then we will have pain. And the stimulation sends an impulse to the brain along a specific nervous pathway. A few problems with saying that this is all and the only way of perceiving pain is that it doesn't explain phantom limb pain. If there has to be a specific nerve that needs to be stimulated in order to feel pain, then it doesn't explain why amputees will complain of pain when there's no limb and therefore no nerve. So this theory doesn't work in those situations. Also, it doesn't explain why people react differently to pain. If we all have nerves for pain and we stimulate a particular nerve when we have pain, we should all experience pain the same, but we obviously know that we don't. Everybody experiences pain a little bit differently. So again, this can't be the only explanation defining pain. And another problem is, why would some animals have been able to be treated or trained to react favorably to a noxious stimuli, as was done in Pavlov's experiments, where he could have the dogs respond to a shock, which is the negative pain of the stimuli, but they would respond in a positive way. When they got shocked, they got fed. So we know that there appears to be some sort of involvement at the brain level or the cerebral cortex level that can modify pain. So there needs to be more involved explanation with pain. The next theory then that was developed was the pattern theory of pain. This says that the intensity evokes a pain of impulses that is interpreted by the brain as pain. This theory denies the existence of pain receptors, and it states that pain occurs when the rate and pattern of sensory input exceeds a threshold. Bottom line, there's slow conducting nerve fibers carry pain, fast acting nerve fibers carry other sensations. And normally fast conducting fibers will override pain. And under pathological conditions, the intensity of the stimulation in the slow system becomes greater and will dominate or overtake that fast system, and then that's why we have pain, or so the theory tries to explain it that way. There's two problems. One is it's too general. It doesn't explain some specifics, and it does not account for the physiological evidence of a high degree of receptor fiber specializations. So if pain is based on a pattern of impulses, we should not expect to see so many receptors that have specialized endings. So it doesn't, again, while some of it seems to be true and works in experience, it doesn't seem to explain all of pain. Then is the gate control theory, and this one is probably the first more comprehensive theory of pain, or the explanation of pain. So it integrates the specificity and the pain theories that we just discussed. The pain perception or modulation takes place at the spinal level, and it proposes what's called a gate mechanism, which is located in the dorsal horn, and it will and allows only one sensation at a time to pass through to the brain. So we'll kind of go into this one in a little more depth here. So if we draw this out in a schematic, we have a blue line that's labeled A beta fiber. And this is going to represent our A beta fibers that carry messages of touch, pressure, moderate cold, moderate heat, more sensory input. And then we have a green line that represents C fibers, which are small unmyelinated fibers that carry pain signals or messages. And then below that we have the black line, which represents A deltas, which are large myelinated pain fibers. So the pink box in the middle represents the area of the spinal cord, and that's where the synapses are located. And specifically, there's a white oval there labeled pain detector. And that pain detector is actually a structure called the substantia gelatinosum, and it's housed in the dorsal horn of the spinal cord. I'll show you a picture of that in a minute. The blue area shading is the area of the brain, and of specific interest is an area called the PAG, or the periaqueductal gray matter, which is a control center for pain modulation. So let's follow a pain pathway according to the gate control theory. So pain receptors, which are the black and green lines on the picture, say they're stimulated and a pain message starts towards the spinal cord, that pink area. The gate control theory then states that only one stimulus can be perceived at a time at each level, or at a synapse. So the pain message, if it's not challenged by another incoming message, will continue through the substantia gelatinosum area and synapse, and then continue up to the brain, where pain then is recognized. The theory states that if we provide a stronger stimulus that travels faster than that pain message from the C fiber and A deltas, then we can decrease that pain message. So if we could stimulate the big blue fiber, or on the line, the A beta fiber, if we could stimulate that with a modality such as cold or heat, touch, maybe E-stim, and this message, these fibers are big, they're myelinated, and they can arrive faster at the spinal cord than a pain message. So if they arrive at the substantia gelatinosum in the dorsal horn of the spinal cord, it will excite or stimulate the substantia gelatinosum. And when that structure is stimulated, it closes the gate on the slower message from the C fiber and the A deltas, the pain message. And our pain seems to decrease. This theory seems to be correct when we experience pain in life. For example, if you drop a weight on your toe, you're going to stimulate the A delta fibers, and our automatic response is to rub it, so to provide some sort of sensory input, which would be stimulating the A beta fibers. So if we rub our foot, it seems to provide an experience that we decrease the pain. And so we would have effectively then closed the gate, or the substantia gelatinosum would have closed the gate of the message from the C fiber or the A delta fiber from going to the brain, and thus we would have less pain. This is a picture of the substantia gelatinosum, and in the upper right is one of the dorsal horns, and you can see the structure of the substantia gelatinosum. That's just where a lot of nuclei and synapses come together, and it's kind of the gate area if we're going to have some modulation of pain by another structure such as the A betas. That's where that takes place. I've come up with like a little cartoon schematic. Hopefully this provides a simplistic way of remembering the theory. So it's just a review. We've got our A betas, which I call the big dogs, and the A delta C's are the little mice, and the substantia gelatinosum we're going to dub Sleeping Garfield. So he's chilling out, not really doing much, and anything can get past him. And then the big T, which is the refrigerator, T meaning thalamus. So let's review this. If we have mice coming in, they're carrying a message of pain, and the substantia gelatinosum, or Sleeping Garfield, is inhibited, the mice will go right past Garfield, and they're going to head right to the thalamus and cause havoc, and pain messages are going to be recognized and received. If, however, we're able to stimulate the A betas, the big dogs, they will cause enough commotion to wake up Sleeping Garfield, and Sleeping Garfield then will go after the mice, closing that route that they have directly to the big T, or the refrigerator. And this seems to be exactly what happens when we're trying to decrease pain in therapeutic modalities, that if we can provide the right modality to stimulate these A betas, then the pain does decrease. And that's really what modalities is about, is decreasing pain or the perception of pain so that we can move on to exercise or activity. All right, a few more theories then. Collectively, these are grouped under what's called descending pathways for pain control, because the pain message has already reached the brain and the pain modulation takes place after that. And so it would be descending messages coming back down the spinal cord. So stimulation of other structures in the higher centers seem to be important. A couple of structures of the raphe nucleus and the periaqueductal gray matter. So in this schematic, you can see it looks really similar to the gate control theory, which is on the left. On the right, however, it lays out a schematic of the line number 1 going up to the brain. That's the pain message sent up to the brain, stimulating the PAG, periaqueductal gray matter, and the raphe nucleus, which sends a message back down to the T cells. And when they do that, they actually will release some enkephalins, or in this case, it's actually endorphins, and we have a decrease in pain. So we've stimulated a higher center, which causes a cascading effect, which stimulates some endogenous opiates lower down in the spinal cord and then decreases pain. So that is another theory added on to the gate control. Another descending theory is called central control trigger theory. It's a modification of the gate control theory in that it involves all the gate mechanism plus an enkephalin release. And this enkephalin release takes place then to cause a decrease in pain. So we receive impulses from the large and the small fibers to inhibit or facilitate the T cells and thus increase or decrease pain. So you can see in this picture, if we look at, here's substantia gelatinosum, and we have the T cells, it's saying that this control center stimulates a release of enkephalins down here. So it's really similar to the previous one, which was talking about endorphins. The last one then is the neuromatrix theory, matrix theory of pain. And this states that pain is multidimensional and biopsychosocial. It says that genetics will be playing a part in determining a person's neuromatrix, which is modified during life by sensory experiences, psychosocial factors, prior pain experiences, emotional events, and life stresses. These can all either increase or decrease pain that someone experiences. The treatment goal is to decrease anything that could be interpreted as the body being in danger. So in therapeutic modalities, we might decrease pain with cold or cryokinetics in order to introduce some exercise. So without the cold, person might say, this is hurting and I don't want to damage my body anymore, so I'm not going to do this. But if we can decrease the pain and so that it is not perceived psychologically as the body being in danger, then we can perhaps introduce some therapeutic exercise. So in a nutshell, I would say that the neurometrics theory of pain is stating and emphasizing that pain is not just a physiological event, which I'm sure that you have experienced or at least seen in other people. So hopefully that adds some clarification to the pain control theories.